Testosterone replacement therapy. What do the guidelines currently recommend in terms of treatment? Today, what we're going to do is evaluate different pieces of literature and their current recommendations in terms of how you should treat guys who have low testosterone. All right, you ready? Let's get started. All right, so the first thing I want to look at is taken from Uptodate. See up here, uptodate.com. Now, if you're not aware of what Uptodate is, it's a compendium, it's a resource compiled of all the most quote unquote up to date, most accurate, up to date literature for clinicians, for prescribers to actually access. I mean, they've got things range from hypertension to nephrology to endocrinology to infectious disease, everything, et cetera, et cetera. So if you're a clinician and you want to find what the most current recommendations for treating a condition is, we would defer to up to date. Now, I'm going to talk about TRT in the context of injectable therapies only today. Anything else other than that is beyond the scope of this video. All right. In this piece of literature, Up to Date says that the data suggests that testosterone enanthate can be administered once every 1 to 2 weeks in most men. It can also be done every 3 weeks in a few men, but never every 4 weeks. And it said the doses used in the studies were considered all somewhat excessive. So in summation, they do recommend that most doses for most men is 50 milligrams up to 100 milligrams every week, or 100 milligrams upwards to 200 milligrams every 2 weeks. So for the most part, 50 to 100 once a week, or 100 to 200 every 2 weeks. Now, it says less information is known about cypionate, but the few studies that it's been performed in suggest its characteristics are similar to enanthate. It says that enanthate has been in short supply, so cypionate may be the most available long-acting ester, and that's what we primarily use. That's what a lot of our compound pharmacies use is cypionate. Now, it says another advantage of enanthate and cypionate over other administration forms of testosterone is that they're biologically effective in maintaining virilization, and that it's another advantage is that you're free from daily administration. Well, I got to say, we do have some patients who do subcutaneous injections with a small dose of testosterone, maybe like 0.1 or 5 units on insulin syringe. We have a very few amount of people that do that once a day. It also says one of the disadvantages of using these esters is the need for a deep IM administration every 1 to 3 weeks. And that brings us to the last part I want to talk about with Up to Date, was that it says that the fluctuations are more pronounced with longer dosing intervals. Obviously, we know that. And it says that disadvantages are the need for a deep IM administration of an oily solution. However, if I click here on sub-Q, it says a formulation of testosterone enanthate for sub-Q injection by auto-injector once a week is now available. This one's called Zyosted, and it's testosterone enanthate. Comes in a little preloaded pen, and you just click, and it administers it once a week. Now, it says insufficient information is available about its use in men with marked hypogonadism. However, of note, subcutaneous testosterone has been used for the management of transgender men. So, for what it's worth, I don't know why there would be a stark difference between people transgender versus cisgender when it comes to giving testosterone. We've treated both, and honestly, I wouldn't treat either category of patient with long intervals of testosterone. In most of those patients, they're usually doing at least minimally once a week, and those are outliers. Most of our patients, I'd say at least 90% of them, are doing at least twice a week. The next thing we're going to look at is the Society for Endocrinology guidelines for testosterone replacement therapy in male hypogonadism. And this one was revised, it looks like October 2021. Let's go ahead and proceed to their testosterone intramuscular injections section. And it refers to short-acting testosterone, which in this case we would presume would be either cypionate or enanthate, given that the other option would be the long-acting, which would be undecanoate, and undecanoate is known as Aved. Anyway, so the short-acting, which again, CYP or enanthate, should be administered every 2 to 4 weeks or subcutaneously once every 7 to 10 days, depending on the formulation and patient response. It also follows up and says administration of testosterone cypionate and enanthate by sub-Q injection at 50 to 100 milligrams once a week has comparable pharmacokinetic safety and tolerability as compared to intramuscular administration and a steady state concentration between dosing intervals. Now right here, it recommends looking at table 2 for testosterone injections. So let's scroll down, take a look at table 2. We're at table 2 right here, and I'll scroll down. All right, so testosterone enanthate or cypionate, the dosage recommendation is 150 milligrams upwards to 200 milligrams intramuscular every 2 weeks, or 50 milligrams upwards to 100 milligrams intramuscular or sub-Q once a week. So these dosage recommendations, again, look kind of similar to what we just saw a few minutes ago while I was looking at Uptodate's recommendations. And the last one we'll look at today is the evaluation and management of testosterone deficiency. It's from the American Urological Association. And this one looks like it was accepted for publication in March 2018. As I was scrolling through this, reading this document, one thing I really do appreciate was in terms of testosterone replacement in patients who have prostate cancer. Now, it talks about patients with testosterone deficiency and history of prostate cancer should be informed there's inadequate evidence to quantify the risk-benefit ratio of testosterone therapy. I'm going to go right here to active surveillance. If you don't know what active surveillance is, it's when you have prostate cancer, but they're not really doing any intervention, not really treating it, most likely because your life expectancy is in the time frame that some other etiology, something else is going to kill you before the prostate cancer does. So that's active surveillance. Now it says there's limited data on men on active surveillance who are candidates for TRT. Available literature indicates that patients with and without high-grade prostate neoplasias who are on TRT did not experience significant increases in PSA or subsequent cancer diagnosis as compared to men not on TRT. This is good because a lot of clinicians want to blame prostate cancer on TRT, and the old adage was that if you got prostate cancer, you had testosterone to it. All you're doing is just adding fuel to the fire. When in fact we know testosterone, it's involved, but it's not the direct cause of prostate cancer. Hence why there's so many men that have had low testosterone 30, 40 years. They're 60, 70 years old, they have prostate cancer. Well, I mean, if they've had prostate cancer and they've had low T for the last 30 years, was it really the testosterone? No, it was the trials in the early 2000s by Morgenthaler really debunked that myth. Anyway, I'm going to talk about the actual treatment algorithms for TRT. I'll scroll here. Now we are looking at the treatment of testosterone deficiency section of this document. Item number 22, it says clinicians should adjust testosterone therapy dosing to achieve a total testosterone in the middle of the range, of the normal reference range. Now, let me read this little passage to you. It says the goal of testosterone therapy is the normalization of total testosterone levels combined with symptomatic improvement. And the panel recommends that testosterone treatment programs use the minimal dosing necessary to drive testosterone to the normal physiologic range of 450 to 600 nanogram per deciliter. Now, I got to say, there have been plenty of patients we've treated who started TRT with a total testosterone of 450, 400, 500. And those guys were symptomatic. They had every symptom in the book. They brain fog, chronic fatigue, low libido, depressed, anxiety, apathetic about life, no vigor, in other words, just a zombie, just a shell of who they were. And with that being said, I mean, the recommendation is to get them to 450, 600-ish. We've started guys on similar levels. Now, it doesn't really make a recommendation based on free testosterone, based on SHBG values. They're primarily just looking at the total testosterone levels. This guideline doesn't really tell you which modality, which form of testosterone you should use. It primarily just focuses on getting the patient to a 450 to 600-ish range. Now, it does say that you can use aromatase inhibitors, HCG, if they're worried about fertility. It recommends not using compound testosterone and only using the branded, commercially manufactured testosterone. And one of the key things it also talks about is, in terms of follow-up, it says clinicians should discuss the cessation of testosterone after 3 to 6 months of therapy in people who reach target levels, which is 450 to 600, but don't have symptomatic improvement. Now, if you look here, please refer to Table 7, Supplementary Guideline, and here's what I'm talking about. Right here, it says therapeutic levels 450, 600. These are where guidelines, or that's the targets where you should fall. And if they reach these targets but they don't improvement, then you should discontinue therapy and look for some other etiology. So let's scroll down here. Here's the treatment algorithm. Obviously, you identify if they're a possible candidate. If they are in fact a candidate, you've got these different options. Again, it doesn't really tell you what dose you should use, but instead it's just focusing on hitting a certain blood serum level of total testosterone. After seeing these different guideline recommendations, what are your thoughts? I can tell you, my opinion is that the vast majority of patients, well, these recommendations aren't really going to cut it for most patients. It's not going to provide the symptomatic improvement that a lot of patients will need. First of all, I mean, dosing intervals of 10 days, 12 days, there's just too much roller coaster, too much going up and down between injections and administrations. Also, if you're targeting a number, that really doesn't actually reflect where most patients feel symptomatic relief at. We've got plenty of guys who may feel amazing at 700, 800, and we've got guys that may not feel a darn thing when they're 700, 800. And thus, if they are targeting just a specific range, you're going to leave so many patients behind that are not being fully symptomatically addressed. Again, we got folks that are like 1100, 1200, and life is amazing. They feel great, cool. But if we apply that to this guideline model or this insurance model, guess what? They're not going to get the treatment they need. And most likely they'll just get punted back and forth between specialist and their primary care with really nothing get resolved. And they may just leave on an antidepressant. Anyway, I hope you enjoyed the video. Hope you thought it was informative. If so, cool. Give us a follow, give us a subscribe. Until next time, we'll see you later.